Morning everyone. Welcome to Bristol. This is my first face-to-face meeting for over 2 years. I'm used to doing webinars, so you're going to have to give me lots of smiles and friendly body language because I'm not used to presenting over the last couple of years in front of all of these people. I just want to take you through the Connecting Care journey. I wasn't able to bring a clinician along with us today because they're busy, but I have included some quotes from some of our providers in the presentation. So, like many of you, we really aspire to sharing information within our region. Connecting Care is an exemplar shared records programme, and in some ways we're lucky. We're 9 years ahead of a lot of the RCSs, and in some ways we're unfortunate because you've got some new technologies that you can use to actually share your information. It's an essential part of our information sharing culture, and we have over 20 IT systems contributing data to our shared care record. We've got 8,000 users using our platform, and we're just about to hit 1,000 records per month. So we started from a low user base 9 years ago, and we've been chasing that 1,000 record target for a long time. We're one of the few shared records that shares children's information, and I think we're ahead of most RCSs in sharing social care information. In Bristol, we've got 3 local authorities, and that focused our minds 9 years ago because Bristol had a lot of serious case reviews. They had a serious case review every single year. So that brought us all together to actually think about how we could share information more efficiently and more wisely. Obviously, the lack of information sharing was cited in many of the serious case reviews. One of the local authorities, Bristol, funded the first year and the proof of concept with 2 of our hospitals and Andy Kinnear, who was working for STW at that time, to prove the case. The other 2 local authorities, though, were at the table, even though they weren't contributing financially to the proof of concept. That seems such a long time ago, and we're now bringing care homes and dom care providers into our programme of work. We've now got 57 care homes viewing our shared care records and 2 of our strategic dom care providers. I just wanted to show you the breadth of the partners that are viewing the Connecting Care record. So we've got the hospitals within our region, we've got our mental health trust, we've got our blood and transfusion units, we've got our 3 local authorities, we've got our community providers, but we've also got some of our very specialist services, so those that support substance misuse, those that support triage for those hard to reach. And we've also got the hospices viewing Connecting Care. I'm not technical, but just a very quick slide on the technical architecture of Connecting Care. So, like all of you, we've got our systems feeding into the shared care record. We've got all of our social care systems feeding in from adults and social care. We've got our community records feeding in. We've got our mental health record. We've also got our 111 and out-of-hours services. And then, of course, we've also got our GP records. Over the last few years, we've also been incorporating those more specialist data sets, like controlled medications from our substance misuse team. Bristol's got a very high homeless cohort, and they need protection and support to make sure that they don't fall between the cracks. Besides the platform, Connecting Care is also a programme, and we receive our discharge summaries into the platform, but we also onward share them to our GP surgeries. So we use that using the Orion technology, and we're currently investigating how we're going to share our discharge summaries out of area. Also, over the last 4 years, we've also been sharing information with PHRs. So in Bristol, our PHR of choice is now MMR from University Hospital Southampton, but we are also sharing information with PKB. I know we're all at different stages of our journey, but this is what we're currently sharing in Connecting Care. So from our hospitals, like most of you, we're sharing our appointments, we're sharing our documents, our discharge summaries, we're sharing our pathology reports and our pathology results and our radiology reports. From our community providers, we're sharing consultation notes, appointments, vaccinations, medications, allergies, and diagnosis. For mental health, we're sharing our crisis plans, our perinatal and contingency plans. We're also sharing core information and the alerts and the discharge summaries. More recently, in fact, in the last 3 months, we've implemented IAP information into Connecting Care. So IAP is talking therapies. So we use the Maiden system within Bristol, North Somerset and South Gloucestershire. And I think we were neck and neck with Devon on our implementation of that information. We've got a proof of concept with one care home where we share information from person knows best. Is that right, person knows best? For the care home system. So we've got one care home sharing their information into the record. Many of you have known me for several years and I'm passionate about social care. That's my background. I've previously worked in local authorities. So I'm always pushing to share the adult and the children's social care information within our Connecting Care platform. Some of this information requires discussion and debate, but we've been really lucky in our region that because of the serious case reviews, people believe in the value of sharing. So we don't have any locked records in social care. All of those are shared into our platform. And then, of course, we share our information from our GP practices. We've got so much more to do, though. So this is 10 years, and we've still got things on our roadmap. So in hospitals, we are putting clinical correspondence into our shared record, but as more and more departments go onto the corporate document management systems in our hospitals, those are feeding through into our shared records. We're also looking to share medications from our hospital systems. We're looking to share documents from our community providers, and we're looking to share more information from mental health. Within social care, we've implemented the capability to share assessments, reviews, and plans, and also our telehealth and equipment documents. It was a more challenging conversation about which of our children's documents we could share, and despite us actually having a flat role-based access, we've decided that those children's documents should only be shared with the children's workforce. We've still got organisations in our region that are not sharing. So like many of you, we're waiting for the ambulance service to aspire to come onto our shared care record. Jeff is here today. We did a discovery report together about sharing prison data into the child care record. We've got 4 prisons in Bristol, North Somerset, South Gloucestershire, and previously they were escorted to the train station by the prison service. They're now given cash and they get stuck in Bristol often. So again, we want to protect that cohort and make sure we've got health information from when they were in prison. And then, like all of you, we're looking to share more care plans. So we're currently focused on our frailty care plan and our long-term conditions plan. Because I'm from social care, of course, I must talk about safeguarding. So I've just brought out on the slide very quickly how our information supports safeguarding in our region. So I talked earlier about the capability that we implemented to share documents from social care into our Connecting Care platform. So that capability has been implemented and we're now rolling it out with the local authorities. So with the children's documents, which are based on role-based access to the children's workforce only, we're sharing our initial conference outcomes, our child protection plans, our child protection reviews, and the record of strategy discussion. With the adult documents, it's more comprehensive. So we've got all of the assessments and reviews and plans, the reablement plans and assessments, the occupational therapy assessments, and also the technology referral forms and the uninstall forms. So I've got a spelling error on this one, unfortunately, but 10 years in the journey, we implemented our care home project a couple of years ago. We've done lots of things over the last 10 years, but working with the care homes actually reminded me how grateful people are for this information and what a privilege it is to share it throughout the system. So we were given funding from NHS Digital to Connecting Care and our care home so that they could view the record. As many of you know, many of them rely on postal services and phone calls, or more recently, access to NHS mail to pass and share information. We were part of a Social Care Pathfinder programme, and we've used VPN to link the care home to our HSCN network. We've only let care homes that have reached standard met on the toolkit to use the Connecting Care platform. During that project, we worked with PRSB, who are here today, to work with them on the About Me standard with NHS Digital. We also contributed to the core information standard, and we also provided them with a care home view. So Connecting Care aspired to make sure that all of our developments are reusable and that we're not supplied to specific suppliers to work with. So I haven't brought a condition to bring my wingman today, but here are some quotes from our care homes that remind me actually of 10 years ago when we just started on this journey. So obviously they're looking to use the care record to be able to provide the correct care. But they reminded us that they've got very complicated patients in their settings, and they too are focused on patient safety and to ensure they've got good communications to provide good direct care. Care homes, like the rest of the health and social care system, want to make sure their residents don't have to retell their story. They also want to be able to explain to their residents about their medicines, because that's often a source of anxiety and frustration for older people. More recently, care homes have been undertaking assessments on behalf of social care. So not only are they looking at this information to inform those annual assessments, they're also making decisions about whether they accept residents into their care homes following hospital admission. So they are becoming leaders in clinical decision making by using connecting care. They've got better information to enable them to make decisions about actually supporting their residents and making sure that they go to better settings before they come home. They've also mentioned that they can now see the respect form, which often is changed in the hospital setting before the residents come home. They want to make sure that they're not overdosing people or underdosing them following prescription change. And like all of us, they're extremely busy, so they now use connecting care to support their shift change so that things don't get missed. We also found some unexpected findings. So our care home told us that they're now better at wound management because they could see the community record. They also told us that they were better at doing their medicines reviews for the CQC, and they were actually hitting those targets to make sure that that was done. What's gone well over the last 10 years for us? This is a personal reflection and not a programme view. So safeguarding heightened our awareness about the importance of information sharing. We spend a lot of time running workshops to make sure that we ask social care professionals in particular and early help teams what information they shared and why. We've spent a lot of time going at the pace of each organisation. So one of the mottos in the Connecting Care programme is don't let perfection get in the way of good. Do little and often, and then actually you achieve great things. Over time, we've grown in confidence that in-context launch actually prevents inappropriate access and enables us to audit access to information. And we've also invested time to make sure that all records are shared with those that need it. You all go on a similar journey. So our IG confidence was already very high, but we've gone from 10 role-based access roles to 2. That took 10 years to achieve that. We've also been really mindful to understand the local authority pinch points. So they are looking for opportunities to reduce costs and reduce duplicated services. And of course, health is now doing that too. So we've now got our leaders in the health and care system saying, please don't ring us, looking connecting care first. We've got our occupational therapy services able to stop their services because they can see duplication within the connecting care record. One of the lessons for me was also understanding in our region the local authority red lines. So it was really important to us that we could purge and delete information. So again, that's a journey that we've been on with Orion Health, and we're now able to do that within our child care record. The technical side. We've still got to get the basics right. So we've had to remap our social care information to health terminology. We've had to agree a local information standard. Thankfully, we've now got the core information standard that we can all aspire to. We had to agree how long we would backload our information for when we take on new information fees, and 2 years tends to be our baseline. And we've learned over time to build social care into our thinking, into our UX, and in how we display our information. And we're also using fire standards where we can. CSU, who chairs our substance misuse information from Bristol, were exceptional as a supplier in using those standards. But we've got so much to do. We want to continue to push boundaries and challenge others where people don't think we can share information. We want to make sure that decisions to share are made by the controllers and not by the data processors. And by that, I mean EMIS and 2PP. So we decide what information we want on our shared care record. We continue to review our role-based access. So we've gone from 10 role-based access security roles to 2. We suspect that we will need to increase those again as our information becomes more specialist. And then also, we need to think about how our information sharing supports new modern care. Should we start sharing information where the service threshold has not been met? So where we know there's domestic violence in the home, should we start sharing that in our shared records? Should we start sharing where no further action has been taken for social care? So if we see that many times, would that make us act differently? When do we start putting telehealth information into our shared care record? And how do we decide what information should be in our shared care record over time? We've talked about a consistent approach to using fire information standards, and obviously Orion Health are working with us to put that onto the roadmap, and I think we've got some sessions on that today and tomorrow. Within Connecting Care, we're continuing to engage and lobby, and in my case, insist that social care is included in the information standards. And they're also making sure that our technical design and infrastructure decisions work for the most vulnerable cohorts. And I've just named a few for us, making sure that the homeless and gypsy Romany travellers are protected and we can access their information, making sure that prisoners and ex-offenders' information can be shared. And then we also want to move to a whole system approach to support the levelling up policy. When is the right time to start sharing information from troubled families, the Department of Education and Housing Services? I'm conscious of time. These are the things that we're currently thinking about within Connecting Care. So think duplication and race. How do we expose the duplication of health and social care services? Think family. How do we ensure that we look at the family and not just the individual where that's appropriate? Think carers. How do we make sure that we look after carers and we meet our duties under the Care Act? Think events, not just appointments and encounters. Think telehealth and Internet of Things. How will this information support triage, assess and decide? And then finally, think local authority and community assets. When do we start recognising that some of the other partners contribute to risks and our decisions in health and social care? And finally, a plea from me, help me achieve my New Year's resolution. I've been doing this for 4 years now. How do I get dental information into Connecting Care? So Dental Care is the #1 cause of admission for 4 to 9-year-olds in Bristol, North Somerset and South Gloucestershire. And how do we continue to challenge our thinking about what information is important? Something that social care colleagues tell me, that it's really important to know whether individuals can cut their toenails or not, because that's an indicator of how soon they will need social care. Yet nobody's asked me to put that information into the shared care record.